Good morning, I'm Jim Monaghan, and welcome to the Jersey Magazine. October is Breast Cancer Awareness Month, and on this final day of the month, our guest this morning is Dr. Michele Blackwood. She's the Northern Regional Director of Breast Surgery for RWJ Barnabas Health. Dr. Blackwood, good morning, and thank you for joining us.
Thank you. Thanks, Jim, for having me. Halloween is a big day for us to celebrate.
Do you have a costume?
No costume. Just a lot of pink. A lot of pink in October.
Medicine is constantly changing. Medicine care is constantly changing. How has treatment for breast cancer changed recently, Dr. Blackwood?
So we're seeing a huge shift in the change of breast cancer. We're zeroing in and what we call de-escalating. So in the 1990s, if you notice, that's when the survival rates got to be much higher. In the 1990s, we went to lumpectomies and radiation, and we gave everybody chemotherapy, and we gave everybody anti-estrogen pills. And now, during the 2000s, we stopped taking out as many lymph nodes, we stopped doing as much surgery, or we also added reconstruction. So a lot of reconstruction, if a woman has a mastectomy, can be done at the same time she has her mastectomy, so she wakes up looking good and feeling whole. I would say, surgically speaking, the surgeries have become much more refined. They're much more tailored to what the patient is looking for. If she has a gene mutation or chooses mastectomies, many times we can literally leave the nipple, we leave the skin, we fill in that defect with her abdominal wall fat or muscle or an implant. So the woman, patients, a lot of them feel much more comfortable about themselves. So they're cancer-free and more comfortable. So surgically speaking, we take out many less nodes. Sometimes we don't take out any lymph nodes. If we have a patient that's over 70 and her tumor is small and her lymph nodes look good, many times we don't have to take out a lymph node, which is a huge help for many women who are worried about chronic swelling of the arm. And as far as systemic treatment, meaning chemotherapy or anti-estrogen pills, we've come a long way with that too, Jim. We used to give everybody chemotherapy in the 1990s, but the reality is that many women probably don't need it. And now we do special tests on the tumor to decide many times if a woman even needs chemotherapy. So, and in the chemotherapy realm, we give certain medicines to certain women for certain cancers and certain for other. So it's become much more refined and de-escalation, meaning that people we used to give chemotherapy to many times now only need an anti-estrogen pill.
Now, is that when you talk about overtreatment? Because I saw that word pop up again and again as I was looking for information on this. Is that what that refers to, overtreatment? And if so, what are the dangers of overtreating?
Sure. So in the 1990s, women said no more. We don't want to die of breast cancer anymore. And the good news was we really did start to accomplish very long lives. As you know, you probably know people who were diagnosed in the 1990s, and thankfully they're around today and doing very well. So we didn't have genomics back then. We didn't have the DNA or the RNA of tumor cells. We didn't know quite how to categorize it. So any woman who had a lymph node that was positive or had a tumor that was greater than 1 centimeter, which is very small, automatically got chemotherapy. Well, the reality is that maybe some of those women, yes, it helped with breast cancer, but maybe some chemotherapies can cause other things. One chemotherapy in particular could cause leukemias. Another chemotherapy could cause a woman to go into menopause. There are a lot of some chemotherapies affect the heart. So we certainly know these women now are going to live nice, long lives. So we want to keep their heart, their lungs, and the rest of them perfectly intact and perfectly healthy. We don't want them to suffer any sort of side effect from something we would give them.
You know, I've been talking with various people over the course of the month, and the mental aspect of being told that you have cancer it certainly hits home. I know when my own mom was diagnosed with breast cancer, and I think it was probably 2001, Dr. Blackwood, the first doctor she spoke with had a very kind of even tone about the whole thing, and well, we'll do the best we can sort of thing. And I remember talking with my mom afterwards when the whole thing, we realized, okay, this is what we're dealing with. And we went to another doctor who was very close to my mom. And I said, we're not comfortable with the first doctor we spoke with. So she recommended another one. That doctor, upon meeting my mom, looked at her and said, the way you act, your demeanor, everything, we're going to beat this. You have a nice long life ahead of you. And she lasted another 20 years, as a result of that. And it was that doctor who just took the time to not just look at her as a patient, but to look at her as a person, like as someone's mother type of thing. I remember saying to one person, imagine this is your mom. That's who I want you to talk to. So I think the mental aspect of that is a huge portion of this. Can you comment on that, Dr. Blackwood?
Sure. So something that people should know is that after a diagnosis of cancer, anybody, man or woman of any type of cancer, your cognitive function, meaning your ability to take facts and incorporate them into your brain as a rational human, goes down by 40%. And that's without anybody touching you, any chemotherapy, nothing. It's just your brain freezes. And we know that. So the first time I meet with a patient about her or his breast cancer, many of the times, the first thing I do is say, how are you doing? Because I want to know, like, where's your brain? And I have to say, now that we see people with masks on, it's a little more difficult because I have to see it from their eyes up, whether they're fogging over with me. And then the next thing we talk about is, look, we're talking the word cure here. We're doing this for cure. We're not doing it for anything else. And I do think it's very important that patients find a physician like you guys did that you're comfortable with. I think if you're not everybody has the same kismet, not everybody has the same relationship. So patients, and the good news is we have a lot of good doctors who treat breast cancer, especially in the RWJ Barnabas Health world. And if you're not comfortable with one, we can always find one that you're more comfortable with. So 100% your head needs to be in the game, 100% right what you did with your mom, finding the doctor you like. And the third thing is you need to make sure that someone's there with you, helping you digest all that information. So many options when it comes to breast cancer treatment that unless you have someone there taking notes or really digesting it for you, you won't remember what happened. So your mom benefited from a lot from what you did too. It wasn't just the doctor. And I think that is an important message. You need your team. You need support from your family and friends. You need a doctor who really cares about you and has a great office that also cares about you. And you also need to feel that connection and do what you can as a patient to become a little healthier. I have a few patients right now who are coming up on their surgery. And one of the things I've asked them to do is quit smoking and take a walk for 20 minutes a day, every day before their surgery. And believe it or not, just doing those two things really helps the healing process, because I can do the operation for you, but you have to do the healing. So it's a mind-body connection that is so important, Jim. Totally agree with you.
We're speaking with Dr. Michele Blackwood this morning, the Northern Regional Director of Breast Surgery at RWJ Barnabas Health. And one of the things that we've been saying all month long here, Dr. Blackwood, on WDHA is that women over the age of 40 should have an annual mammogram. What about before age 40? What happens there?
So, Jim, that's a really good question because a lot of people don't understand what's involved. One of the things we do here is we really try to impress upon patients their risk factors. So we have a high risk program here on the Livingston campus where patients can actually evaluate their own risk. So if a patient has had multiple biopsies, her mother had breast cancer, her sister had breast cancer, someone in the family had premenopausal breast cancer, they should be seeing us 10 years before the youngest person in the family was diagnosed. So there are a number of patients in their 20s and 30s who see us here in the office, and we do a breast exam. We either get a mammogram and or ultrasound, and many times we add an MRI to that. And if we do find breast cancers that early, we know that they're probably not going to need chemotherapy. We're talking about 100% cure rate. So we really believe in early detection here, and really for women to assess their risk. And one of the ways they can do it, there are a couple of websites online that can do what's called the GAIL Model Risk Assessment for any woman 35 and over. That's GAIL Model Risk Assessment. There's another one called Tyrer-Cuzick, TYRER-CUZICK. And that's the quiz for that one is IBIS, IBIS. So if they just put it into Google, they'll find those links and they can find out for themselves what is their risk factor.
I was looking up and I saw that 30% of women discover that they have cancer through a self-exam. What's the best way to do a self-exam for a woman?
So a lot of people, there's a lot of disinformation about breast exams. Breast exams can be done in the shower. They can be done lying down. They can be done a circular pattern. They can be done in an up and down pattern. They can be done with soap. They can be done without soap. So 30% of women find their own breast cancers. 30% of their partners find their breast cancer. And the other 30 to 40% find it either with a doctor or with their annual mammogram. So the good news is we want all those things working together. Women say to me, I don't know what I'm feeling. I understand that, particularly if they're premenopausal and still getting their periods. The breast has a lot of nooks and crannies to it, and especially for premenopausal women. But I say to them, look, if you saw a new spot on your hand and you look down, you would say, oh, that's a new spot. I'm going to go to the dermatologist. Same thing is true of breast. It's how you've got to learn the differences in your breast tissue and at different times of the month what they are. So it's more an awareness, we like it to be, than an actual set breast exam, because breast exams in and of themselves are probably not as great as people think they are. At least most of the studies bear that out. But we do like women to be self-aware. And if they are concerned, they really need to see their doctor. And that makes a big difference. We can look into things now. We have ultrasounds, we have mammograms, we have needle biopsies, we have MRIs. There's no reason to feel a lump and say, I'm just going to leave it there anymore.
You mentioned pre-surgery, you recommend women stop smoking and walk for 20 minutes. And I know there's nothing that you can do precautionary that will completely prevent you from getting cancer, but what are some precautions that women can take in order to at least lessen the possibility of getting breast cancer?
So the reality is there's some things we can't change, right? We can't change who our parents were. We can't change what our genes are. We can probably change the color of our hair, but we can't do other things. But there are a few things that one can do to help one's risk factors. One is obviously, and every doctor will tell you this, maintain a good weight, exercise daily, and eat healthfully. Now, if you're going to have a cheeseburger from a fast food restaurant once a month, is that a big deal? It's probably not. You know, if we ate more like our grandparents ate, we'd probably be healthier. Of course, smoking, people are surprised when I tell them smoking actually can cause breast cancer. They didn't realize that they were linked. And I'll be honest with you, many women are not honest with themselves about whether they're a smoker or not. If you go out with your girlfriends and you have a drink and you have a couple cigarettes, that is smoking. So we'd like to cut that out completely if possible. And the other thing is alcohol. Alcohol routine use, more than 4 drinks a week, definitely seems to increase one's risk of breast cancer. We also want to try and reach the college population, which is a difficult population to reach on this subject because they're not exactly thinking about prevention of anything. But the reality is that maybe binge drinking of women in their teens and 20s will contribute to breast cancer later in life. So in all, everything is about moderation. And if we could, most cancer surgeons will tell you, please keep everything in moderation and you'll probably extend your life quite frankly, and for a nice, healthy, long life.
Dr. Michele Blackwood, the Northern Regional Director of Breast Surgery for RWJ Barnabas Health, our guest this morning here on the Jersey Magazine at 105.5 WDHA. You've mentioned it in passing a couple of times, but breast cancer also affects men. What are some of the issues that men deal with that, Dr. Blackwood?
So the way a man usually presents with breast cancer these days is either has bloody nipple discharge from one of his nipples or a mass underneath the nipple. Men have breast tissue, they just have usually less of it. Men are interesting when it comes to breast cancer. They have the same issues that women have in some ways. Some choose a mastectomy, some choose the lumpectomy and radiation. We even do reconstruction for men nowadays, and I don't know that many men know that. We try and gauge it again to the type of cancer they have and the age they are. Many men will go on an anti-estrogen pill after they've been diagnosed. So it's important that if you feel what we call a unilateral or one-sided breast mass, or you have bloody nipple discharge, you should talk to your doctor about it. If you have a painful lump, that's usually not breast cancer. But if it's new and if you're on certain medications, that can also lead to it. We're seeing a lot of young men coming in with enlarged breast tissue, both sides. And I think it's from the increased use, quite frankly, of marijuana. Pot seems to increase what we call gynecomastia, or benign breast tissue. Has not yet been linked to breast cancer. But we are seeing a lot more college-age young men that are coming in with this and worried about it. And then when we tell them what we think it's from, they look very surprised.
I want to thank you so much for your time this morning. For women and men who want to learn more about this, where's the best place for them to go, Dr. Blackwood?
So, of course, we have our rwjbh.org, has some information on it. There are some very good breast cancer sites. One is breastcancer.org. And then, of course, your doctor is always a good source for it. So your internal medicine doctor, your gynecologist, if you're one of our patients who's high risk, we're certainly a good source for it as well. And Jim, I really thank you for doing this work, and especially in the month of October. It's always good to remind people breast cancer awareness and to make sure they come in, get their mammograms. A lot of people have put it off during COVID. We're open, we're ready, we want to see them, and we want to make sure that they're okay.